And good morning, everyone. I'm Dr. Kim Allen Williams, Chair of Medicine here at the University of Louisville. And it's my distinct pleasure to introduce my long-term friend and uh, co-investigator and partner in organizations in medicine. We've been good friends for the longest time, and that is Dr. Keith Ferdinand. He is the Gerald Berenson Endowed Professor and Chair in Preventive Cardiology at Tulane University School of Medicine. I got to know Dr. Ferdinand early on when we were both cardiology fellows and both going to the Association of Black Cardiologists meetings very, very early. He's been a longtime friend and advisor and academician. And he is currently a professor of medicine at Tulane University School of Medicine, as well as professor of clinical pharmacology at Xavier University. He received his medical degree from Howard University, and he is board certified in internal medicine, cardiovascular disease, and certified in my own specialty of nuclear cardiology, and is a renowned specialist in the area of clinical hypertension. He's a member of the Association of University Cardiologists, where he is actually right now, and he has been a past chair of the National Forum for Heart Disease and Stroke Prevention, prior chief science officer and chair of the board of the Association of Black Cardiologists. And he has also served on the board of the American Society of Hypertension, the Southwest Lipid Association, International Society of Hypertension in Blacks, and he's presently on the board of the Partnership to Advance Cardiovascular Health, the NLA, National Lipid Association, and the Family Foundation for Heart, and the American Society for Preventive Cardiology. Dr. Ferdinand has a long history of working in health care disparities. He's worked with the Association of Black Cardiologists Access to Care Initiative since 2016. He's worked on the American Heart Association's National Hypertension Control Initiative, an advisory group that really allows him to share his unique perspective, experience, and expertise in hypertension, particularly hypertension in the African American population, where it's such a burden for our community. He's actually been working with the Office of Minority Health, Health Resources Service Administration, and he serves as an advisor to the National Association of Community Health Centers, the Million Hearts Initiative with the CDC. He's done so many trials, so many publications, so many lectures. He's been a guide post for all of us on hypertension, lipids, cardiometabolic risk, and cardiovascular disease, particularly in racial and ethnic minorities, but not limited to, with over 300 peer-reviewed publications and lectures nationally and internationally. It's such a pleasure and a privilege to host you today, Dr. Ferdinand. Please let us know what you have to tell us about the new guidelines and resistant hypertension. Thanks so much for being here.
Thank you, Dr. Williams. That was so generous of you to give that detailed introduction. I'm very pleased to discuss Hypertension 2025, where we are now and where we're going to be going. There are no new United States guidelines. Our last guideline, the ACC AHA Multi-Society Guidelines, which Dr. Williams worked with, was published after it was released in 2017. But there is a new European Society of Cardiology guideline. I'll mention that, the European Society of Hypertension guideline. And I'll give some insight into the new studies in hypertension and where we may be going in the United States and our guidelines in the future. I also will focus on resistant hypertension. It's a particular phenotype which needs a lot of attention, and we who work in internal medicine and cardiovascular diseases, we see a disproportionate degree of persons with resistant hypertension, and of course, being in the South, we also see resistant hypertension. So let's get going. Here are my disclosures. I'll first talk about the new evidence. The major studies actually are coming out of China that may inform where we're going to be going with hypertension. And I will discuss the European Society of Cardiology guidelines. The last guidelines just released late 2025. With resistant hypertension, we'll look at the new and investigational drugs, and I'll make a few comments on renal nerve denervation. Although we don't have a U.S. guideline at this point that's been recently promulgated, we do have what's called scientific statements. I worked with the scientific statements on implementation strategies how not just to look at the data, but how to apply the data to better control hypertension. If you look across the x-axis, you see that cardiovascular mortality increased throughout much of the last century. Then you see a downward trend starting in the mid-1970s when we start to do better with risk factor control. What's happening now, unfortunately, is that built on the back of COVID-19 and also related to the fact that the population is getting older, more obesity, more sedentary lifestyle, we're now seeing, unfortunately, an uptick in cardiovascular mortality. What's the main problem? Well, it's multifactorial, but if you look across the globe, this is across the world, the major modifiable risk factor that causes cardiovascular death and disability is systolic blood pressure, even more than BMI, non-HDL cholesterol, smoking, and diabetes. And furthermore, although it's underestimated by women, I think most of you know that 10 times more women die from cardiovascular disease than breast cancer. Hypertension is the more powerful predictor of cardiovascular disease in women. Once a woman passes post-menopause status after about 5 or 6 years, the rates of hypertension are actually higher in women, and the impact of hypertension on cardiovascular mortality is higher in women. This is the regression line from the blood pressure treatment trial list collaboration. Going from left to right, you see the reduction in systolic blood pressure. There's a linear, direct, consistent relationship between lower blood pressure and outcomes. I bring your attention to the SPRINT trial. This was the major trial in the United States that showed intensive treatment to a target of less than 120. They obtained about 123 versus the previously conventional target of less than 140. Intensive treatment in SPRINT reduced cardiovascular disease, cardiovascular mortality, and total mortality. Now, SPRINT did not have persons with diabetes, but we now have some new studies coming out of China, large trials, which show that the lowering of blood pressure does indeed reduce these cardiovascular events, whether or not the person has diabetes. And I'll show you the data to support that. And there's also a Chinese study that shows that this benefit is present in older persons. It's going to be called STEP China. One is called BP Road, and one called eSpirit. These have come after our 2017 guideline, so it may inform where we're going to be going in the future. Here's the problem that we have. On the left-hand side, you see in a subpopulation of SPRINT, those who had electronic health records. Intensive is in the dark yellow or orange. You see the blood pressure came down, and during the trial, it stayed down. Then they observed the patients, but once they left the study, looking 10 years down the road in the subpopulation of SPRINT, what you saw was in the intensive group, this upward drift in hypertension. So they basically went right back to baseline. We need to do more to implement the data that I'm going to discuss on hypertension control. The data are going to be pretty powerful, that lower is better, that intensive blood pressure reduction saves lives, but we really don't do a good job in usual clinical practice. Here's the other problem. These are data from the United States. The different colored bars are the self-identified racial or ethnic minority populations, but it really doesn't make a difference. When you look at the left, awareness is high, treatment is pretty high. Where we fall down across all of the various populations is in control. And in the yellow, you see one of the groups, non-Hispanic Black populations, not only having higher rates of hypertension, but poor control of hypertension. Why is this important? Well, I'm a cardiologist and we see heart failure. The internist also sees heart failure, but it's driven not mainly by coronary disease. In the clinical trials, we see coronary heart disease as one of the main drivers, but in a population attributable risk, going again across the x-axis, I'm showing you data that's for years, for decades. And again, I'm showing you hard data, mortality. The top dotted line, non-Hispanic Black or African American, the risk of heart failure, much higher with mortality that persists for decades. You look at another disease state, end-stage renal disease, driven mainly by diabetes and hypertension. Although there may be some genetic factor in persons of West African descent, it's primarily poor control of these risk factors that predicts end-stage renal disease rates 3 times that which would be predicted by population alone. So we have some real problems. Let's look at some of the newer data and how it may inform what we're going to be doing going forward. This is a trial called Spirit out of China. The sample size, large. Most of these Chinese studies have large populations, 11,255 persons. It's similar to what we saw in Sprint, 120 versus 140. What's a little different is that they did include persons with diabetes. Sprint did not have persons with diabetes. And what they showed was that for these hypertensive patients, regardless of their status of diabetes or having a history of stroke, the treatment strategy of targeting less than 120 compared to less than 140 prevented major cardiovascular events, and they only saw a minor increase in risk with more intensive blood pressure reduction. Here is the blood pressures comparison, and you're going to see a similar type of graph when I look at the other studies. This one is from the Spirit trial. Intensive in the light blue, they got the blood pressure down fairly quickly and kept it down for up to 4 years. With a target of less than 120, they obtained a blood pressure of about 122. Here's the forest plot, one being no difference between intensive and standard. Looking at major cardiovascular events, it lies to the left. Statistically significant decrease in major cardiovascular events. Decrease from death in any cause. Now, that's a difficult thing to achieve in any clinical trial, but it was achieved in this study. And the primary outcome of death from any cause, again, statistically significant. Here's another major trial, again, out of China. This is 8,511 persons. They look at older persons. And in these older persons, again, looking at the more intensive targets, 110 to 130, they show a lower incidence of cardiovascular events compared to standard treatment. Here's the similar diagram looking at the blood pressures that were obtained. In the intensive treatment, they were able to get down to 127, the standard treatment 135. Now, 135 is better than what we see in usual clinical practice, but in this particular study, in a large cohort and continued to show over a period of 4 years, decreasing blood pressure to a more intensive target shows statistically significant reduction in the composite outcome of major cardiovascular events. Note they also include heart failure, which may explain some of the disparate rates of heart failure in the Black population in the United States, coronary vascularization, atrial fibrillation, another target for blood pressure reduction, and death from any cause. The third large Chinese study was a study called BP Road, again, published New England Journal of Medicine. This is the latest one. It was just published in November of 2024, and they specifically targeted those patients with type 2 diabetes. I'm going to move along real briskly because it'll give us an opportunity maybe to have some discussion about this. At one time, we thought because a cohort study was negative, that this intensive target did not also involve persons who have diabetes. But in this particular study, looking at persons with type 2 diabetes, the 120 target versus 140, they showed that intensive treatment reduced major cardiovascular events significantly lower than the conventional target of 140. Here's a similar diagram. Note these Chinese studies all have large sample sizes. So the total sample size on this one is about 13,000. Again, robust blood pressure reduction. It included a significant number of women, 45%, age 64%. They obtained 121.6 intensive, 133.2 in the usual, and the composite endpoint significantly different, showing that it made no difference whether the person had type 2 diabetes or older age. Intensive blood pressure appears to save lives and reduce cardiovascular events. Now, let's revisit the 2017 guideline. I've mentioned that we don't have a new US guideline. One of the things you want to do when you look at the central illustration for this particular guideline is go from left to right. If the blood pressure is normal, you don't necessarily need medications at all. In fact, the bedrock for the prevention of increase in blood pressure with age is lifestyle. low salt diet, fresh fruits, vegetables, the DASH type diet, avoiding saturated fats, weight gain, obesity, physical inactivity, smoking. So lifestyle is still still important as primordial prevention. Next to that, you see elevated blood pressure. It's higher than the normal blood pressure of 120/80. Again, lifestyle. But subsequent to that, when you get to 130, what the 2017 guidelines suggest is estimate risk. And if risk is high, those patients need drug therapy. And this is going to be before you reach the previous 140/90. And something that's often overlooked in those patients who have what is now defined as stage 2 hypertension, 140/90 or above. In those patients, yes, non-pharmacologic or lifestyle modification, but those patients need medications. It's a class 1 indication. You no longer can tell patients who have confirmed to have blood pressures of 140/90 that it's enough just to do lifestyle modification. They need medication. The other thing from the 2017 ACC/AHA Multi-Society guideline that's often overlooked is that for those persons who need these more intensive targets, most of them are going to need 2 or more drugs. It's probably not going to be able to control these blood pressures with one medicine, and it can be achieved by using combination medication to increases adherence. Patients often feel better taking 1 pill versus 2 pills, and they will see it as an easier way to control their blood pressure. But from the guidelines, a class 1A evidence, based on limited data, but it's there, 2 or more drugs are going to be used to achieve these more intensive targets. The 2017 guidelines also noted this is especially true in Black adults who tend to have more severe hypertension. What's going to happen in the future in the United States, we don't know. The pool cohort, which was based on the NHLBI population surveys and the Framingham risk calculation, are probably not going to be used. Going forward, we're looking now at Prevent. Prevent is an AHA promulgated risk equation looking at over 1.5 million persons in the United States. And there's some novel things that we see in Prevent that you probably should now become more familiar with. I think you're going to hear more about Prevent going throughout 2025. One is they're now looking at kidney function as an important risk and includes that along with social determinants of health, SDOH. It's a term of art. It means where people work, live, play, and pray. The environment has a profound effect. So what they suggest that you do a zip code analysis as a surrogate for the social determinants to determine risk. Going around the clock, you see the other conventional risk factors: age, sex, the blood pressure itself, lipids, medication, diabetes. They suggest doing an A1C when indicated, which is true for most patients, especially those with overweight or obesity, and a urine albumin creatinine ratio as a marker for kidney disease, but it's also a marker for vascular disease, and it shows that those patients are higher risk. So start familiarizing yourself with the Prevent risk equation. It's probably going to be the way that we're going to assess risk in all of the future guidelines from the ACC/AHA going forward. The guideline that was most recently promulgated is from Europe. It's the European Society of Cardiology guidelines for the management of hypertension. It was just released in late 2024. In this particular guideline, there's a lot there. I'm going to point out some things that I think are very informative for today's clinical practice. One is they put emphasis on looking for causes of secondary hypertension. Secondary hypertension is a term of art. It means that the person has blood pressure that's elevated, but there's something that, if removed or corrected, can treat the blood pressure effectively. Primary hypertension being those who had what we also call essential hypertension, where you can't identify that one factor. And at the top, they put primary aldosteronism. There's now a lot of data that we're underestimating the degree of primary aldosteronism in the population, especially in patients who have resistant hypertension. It may be as high as 15 to 20%. The baseline of the primary aldosterone workup is the aldosterone to renin ratio. And if that's elevated, then consider looking at other studies to confirm. They also mention renal vascular hypertension. We now know that intervention is not needed unless the person has flash pulmonary edema or rapid progression of kidney dysfunction. But that also is something that we should pay more attention to in our very high-risk patients. The other forms of secondary hypertension, I'm not going to go into great detail now. The European Society of Cardiology Hypertension guideline is widely available. Here's their diagram, their picture for primary aldosterone. And I like it because the Europeans tend to have very colorful guidelines. They use a lot of charts and a lot of pictures. It's easy to read, and it's something that can help you when it's time to try to look at some of these very complicated secondary factors. For primary aldosteronism, they remind us that it's mostly asymptomatic. You don't have to have hypokalemia, but if the person does have spontaneous or very marked diuretic-provoked hypokalemia and difficult to treat hypertension, think about primary aldosteronism. But nevertheless, you can have normal potassium. In fact, real hypokalemia is only present in about 20 to 30% of these patients. They also mention some other things to look for, including atrial fibrillation, muscle weakness, etc. In terms of diagnosis, the aldosterone to renin ratio with confirmatory tests if needed. One of the clinical pearls going forward is you don't have to stop all medications. That is no longer the case. You do have to withhold mineralocorticoid receptor antagonists like spironolactone or eplerenone, but the conventional medicines, including ACE inhibitors and ARBs, can be continued to make the diagnosis of primary aldosteronism. And the treatment, of course, is using the mineralocorticoid receptor antagonist, that's spironolactone, especially for older individuals, men who have sexual dysfunction or gynecomastia with spironolactone. You can use eplerenone. Remember that eplerenone has a shorter half-life and is not as potent. So 25 milligrams spironolactone will be equal to 50 milligrams of eplerenone, and it often has to be eplerenone twice a day. That is one of the main ways of treating persons with primary aldosteronism. If you locate that it's a unilateral secretion of aldosterone, then the person can look for a surgical cure. So the 2024 European Society of Cardiology guidelines, I think, is a big leap forward. The question is, what's new, what's different, what do you really need to know about that that's important? Now, compare the guidelines using this cartoon from a recent editorial. In the European guidelines, they say 140/90 for all, but in those patients who have high risk, you want to treat them if the blood pressure is over 130, over 80. And the goal is less than 140 for all, but those with high risk who are over 85, they suggest that we use some degree of caution because of orthostasis, fragility, and limited life expectancy. In the United States, in our 2017 guideline, we say 140/90 if the person has no high risk, but most patients who we see who are middle-aged and older, those persons who have diabetes, kidney disease, any form of cardiovascular disease, when you do the risk calculator, they're high risk. So for them, it's 130/80 to initiate therapy. Also, the Europeans suggest that you can get down blood pressures to 120 to 129 as low as reasonable tolerated. They also suggest that you consider less than 140/90 for the older persons. In the treatment targets from 2017, it suggested 130/80 for all patients except patients with a recent stroke. We'll see what's going to happen going forward, but the Chinese studies that I've shown you have suggested that robust blood pressure reduction is beneficial for all patients, regardless of diabetes, regardless of 60 to 80 years of age. So I suspect not only will 130/80 hold in any new American guidelines going forward, but it may actually be reinforced. This is an interesting editorial that was just recently published looking at the European guidelines from some of the leading international thought leaders in the field of hypertension. And they did what they called the 10 Commandments of the ESC guidelines. Now, I won't go into great detail, but again, I would suggest that you look at this since this is the most recent international guideline. Look at their blood pressure classifications. They recommend out-of-office blood pressure. That was also recommended in 2017. Assess risk. They use a score risk factor calculation. I think going forward in the United States, we're probably going to embrace prevent. They look at different targets, whether the blood pressure is associated with elevated risk or high risk. They suggest lifestyle, both for the reduction of blood pressure, but overall cardiovascular risk, low sodium diet, inclusion of fresh fruits and vegetables, potassium, avoiding the fast foods high in sodium, physical activity. Blood pressure targets, as we previously mentioned, the less than 130 for persons who are 85 years or greater. Remember, frailty, limited life expectancy as a factor. They also talk about resistant hypertension and the multidisciplinary approach. I'm going to build on that because I'm going to go into a discussion of resistant hypertension. And when I end with implementation science from the American Heart Association scientific statement, which I was pleased to be a part of the working group, we believe that the multidisciplinary approach, the team-based approach, is the way to go to control blood pressure. It's not enough for the magic doctor's visit 1 to 2 to 3 times a year. You're going to need a team approach in order to control blood pressure. All right, so let's now transfer over to a brief conversation on resistant hypertension. The phenotype is a person who has blood pressure that's still greater than 1/3 of 80, despite being on 3 drugs of the major classes. And if the person has blood pressure less than 1/3 of 80, but it takes 4 drugs or more, they still have resistant hypertension, but now it's controlled resistant hypertension. So for resistant hypertension, what we see is that it actually is a little bit more prevalent than one would think. It's up to 20% of persons with treated hypertension. That's 10 million Americans. It's more frequent in persons who would be self-identified as Black, older age, male sex. In terms of geographic areas, it's higher in the South, probably because you have a higher burden of hypertension and a greater proportion of persons of Black race in the South. It's also associated with major comorbidities in vascular and metabolic abnormalities. And once a person has this phenotype of resistant hypertension, they have twice the increased risk for cardiovascular disease. What drugs to use? Well, we have a lot of blood pressure medicines, but it's suggested that patients be at least on these 3. A thiazide type diuretic. The loop diuretics are reserved for patients who have higher grades of CKD. For instance, a GFR less than 30, you would lose a loop diuretic. But other than that, a thiazide type. Calcium channel blockers. You want to use a long-acting calcium channel blockers. I preferably like amlodipine. It has a very long half-life. Once it reaches a steady state, amlodipine can be effective for 3 to 4 days. And, patients will miss medications, but amlodipine will cover that rebound effect. And a RAS blocker, either an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. Cardiologists love ACE inhibitors. They were the first RAS blockers. But if you look at blood pressure control, ARBs are just as good. You avoid the 10% of persons who have the nuisance dry cough. And it also has less angioedema, which is seen in 1 out of 3,000 persons. In the Black population, 1 out of 1,000 persons. So you can use an ACE inhibitor or an ARB, calcium blocker, and the diuretic. Here's the scientific statement on resistant hypertension. We have not had a new one. This is from 2018, but it stands the test of time. Going from left to right at the top, look for those secondary causes. Remember primary aldosteronism. In the middle, lifestyle. And not only is the low sodium diet, high potassium diet, weight loss, physical activity, but they also included interrupted sleep. And we now know that having appropriate sleep is one of life's essential 8s from the American Heart Association. And once you've removed the secondary causes, you've embraced the lifestyle, then optimize the 3 drugs to repeat: a RAS blocker, calcium blocker, and a diuretic. Often overlooked is that the thiazide type diuretic, and I use this term because these have a construction which is not similar to the thiazide, but their effect is similar. Chlorthalidone and indapamide may give a better benefit. Now, there is some controversy with this. There was a veterans study that suggested that chlorthalidone and hydrochlorothiazide had equal effects. But when you look at the subgroup of patients in that study who had previous myocardial infarction, chlorthalidone did appear to be somewhat better for blood pressure control and cardiovascular outcomes. And in that particular study, they used 12.5 milligrams of chlorthalidone. In order to better control these difficult patients, you're probably going to need 25 milligrams of chlorthalidone. Indapamide is a thiazide-type diuretic. It is used mainly in Europe, but it is available in the United States. And you can use it at a low dose, 1.25, or the conventional dose, 2.5. I like indapamide. It's on the formulary for many of the big box pharmacies for only $4 per month. So it's similar to chlorthalidone. It's often overlooked because its use was mainly in Europe, but it is available in the United States. And the final thing, don't forget the mineral corticoid receptor antagonists, spironolactone or eplerenone for these patients with resistant hypertension. I'm not going to focus a lot. Much of my work is in the African-American population, Black population, especially down here in New Orleans. But this is a study, and I think it's important to recognize that in the Black population, you have higher rates of apparent treatment-resistant hypertension. But when you look at the data from the Jackson Heart Study and the Regard Study, these are two large cohort studies in the South. Jackson Heart Study in Jackson, Mississippi is what you consider the Framingham of the South. It's all self-identified Black patients. Regards is a biracial population of over 30,000 persons. But looking at those two populations, specifically Jackson Heart Study and the Black population of Regards, what they found was in those patients who had apparent treatment-resistant hypertension, very few had ideal lifestyle, 1.2%. So we have a long way to go in order to achieve ideal lifestyle in this population. Very few were using chlorthalidone or indapamide, the thiazide-like diuretics, which I've mentioned may have a better benefit than hydrochlorothiazide, and less than 10% were using spironolactone or eplerenone, which has been shown to be beneficial. This is a very nice review. It was published in August of 2024 by, I am the senior author, and those are some other persons I was working with at the time. And what we looked at was tackling the disproportionate burden of resistant hypertension in the Black population. And we looked across all of the various factors. Some of these things are emerging and not yet approved for the FDA, but others are available. Some are approved for other conditions. For instance, I make some comments on the SGLT2 inhibitors on the left and on sacubitril valsartan used for heart failure on the right. This also has an effect because the sacubitril valsartan combination, although it's approved for heart failure, has an ARB in it, and the neprilyzing inhibitor has a blood pressure effect. The SGLT2 inhibitor, although it's approved for diabetes, CKD, and heart failure, has an osmotic diuretic effect, natriuresis, and does have a blood pressure effect. I'll mention some things on the SGLT2 going forward. But let's look at this schematic that looks at all the various pathways by which we may attack resistant hypertension. There is an investigational agent that's a silencer, an RNA silencer, siRNA, for angiotensinogen, which is the first step in the renin-angiotensin system. It's called zilebesiran. And similar to inclisiran that's used for lipids, you inject it at the baseline 3 months. Thereafter, only 6 months, it turns off the signal that causes the upregulation of the renin-angiotensin system. So zilebesiran is undergoing active investigation. It's well tolerated, does appear to work. The late, great George Baccharis, who is a luminary in hypertension science, was the principal author of the paper that showed angiotensinogen inhibition with zilebesiran, not yet approved. We now know that endothelin is another vasoconstrictor on a millimole basis. It probably is even more powerful than angiotensin 2, and there is approved an FDA drug, not readily available, called aprocitentan, and I'll make a few comments about that. The mineral corticoid receptor antagonists, spironolactone and eplerenone, are effective, but now we have some newer ones that are being developed. One is approved, Ferdinand, probably not as powerful for blood pressure reduction as spironolactone or eplerenone. I mentioned the sacubitril valsartan already, and I'll make some comments on the SGLT2 inhibitors. Let's look at aprocitentan. This was approved. It is just becoming available in the pharmacies. Blocking endothelin A and B, it appears to be very beneficial in patients with treatment-resistant hypertension, but it does not mean that you stay away from the previously well-proven three-drug therapy of a RAS inhibitor, ACE-R, long-acting calcium blocker, thiazide or thiazide-type diuretic, and spironolactone. So it's down the tree of those already proven approaches. This is directly out of the FDA labeling. It was approved in March of 2024. It has not reached its way into all of the pharmacies at this point. They recommend aprocitentan at a 12.5 milligram dose once a day with or without food. In the studies that Dr. Baracus had done, there was a 25 milligram dose. The 25 milligram dose, however, appeared to hold on to fluid, and edema was one of the side effects. The FDA felt that the 12.5 was similar in efficacy without the fluid retention or edema that was seen with the higher dose. I mentioned to you the SGLT2s. This is an interesting study that we did several years ago to look at the hypothesis that in patients with uncontrolled diabetes and hypertension, the SGLT2 may have a benefit. This was published in Circulation. And what we did, going from left to right, you see the downward trend in blood pressure in this cohort, self-defined Black patients, only 52% males, so a lot of females, age 56.8. Real blood pressure at baseline, 145 to 148, so that's stage 2 hypertension. A significant reduction with empagliflozin using 24-hour ambulatory blood pressure, 10.33 millimeters of mercury. And if you subtract the placebo, there was a placebo cohort, that's about 8.5 millimeters of mercury, 24-hour blood pressure. So in those patients with uncontrolled diabetes, not only will the SGLT2 help progression of CKD, it's approved now for heart failure of various phenotypes, and may also have an anti-hypertensive effect. The GLP-1 receptor agonists, we now know cause weight loss. They are not as powerful in terms of the blood pressure effect, but in this cohort of the STEP studies, multiple studies in which they looked at semaglutide along with the weight loss, both in the patients who had various forms of hypertension, 130, 140, even resistant hypertension, it seemed to give a consistent 4.5 to 5 millimeter reduction. Not antihypertensive drugs, but it suggests that with the weight loss, there is a blood pressure effect. This is an interesting paper. It was published in JACC. Small cohort, 50 patients with a Roux-en-Y gastric bypass compared to medical therapy. And they were able to show that 80% of patients could reduce their medicines. About half of them actually went into remission. So gastric bypass with remarkable weight loss also can help control blood pressure. The central illustration suggested after 5 years, not only should obesity be treated, but bariatric surgery may be ineffective and durable strategy to treat hypertension with obesity. I probably would state that a little different. I would say that bariatric surgery, along with weight loss and its cardiometabolic effects, appears to robustly help with blood pressure control. Renal nerve denervation has now been approved by the FDA by ablating the renal nerves using either ultrasound or radio frequency. It is approved by the FDA as an adjunctive in patients whom lifestyle modifications and antihypertensive medications do not adequately control blood pressure. Now, that can be a little bit broad of an indication. I think we as clinicians need to know how to use this tool going forward. There is one that ablates using alcohol. It has not been approved, but you may hear more about that in 2025. The European guideline, remember there is no new American guideline, the European guideline in 2024 brought it from a class 3, meaning potential no benefit or harm, to a 2B, meaning you can consider for uncontrolled hypertension if the patients have their blood pressures not controlled and there's a preference with the risk-benefit discussion. This is a table. Don't worry about the numbers because it's going to be 0 or 1. And what it suggests is that one good thing about renal nerve denervation, it appears to be relatively safe, both in terms of peri-procedural and post-procedural complications. They seem to be very uncommon. An article that we published looking at the Black Americans in one of the renal denervation studies was very informative. What it showed was the renal denervation in the intervention group versus the sham group had no statistical significant difference in the Black cohort. Now, if you go further into the data, or what they used to say, the rest of the story, is that in the Black American cohort, in the sham group, the reason there was no difference versus renal denervation because the patients, once they entered the trial, had a remarkable increase in medication from baseline to 6 months, p-value 0.003. The take-home message that I use here is before grabbing the catheter, make sure that the patient's taking their medicines. And that's one of the main reasons for poor blood pressure control is non-adherence. We as clinicians don't intensify therapy. Patients don't take the medicines. That is an indication that we need to do better with conventional blood pressure medications. Good effect of renal denervation, looking at the sun and the moon, both with medicines and without medicines. This is one of the studies that looked at renal denervation and showed the 24-hour effect. We know that nocturnal hypertension or early morning surge predicts risk, so having that always-on effect is considered very beneficial. This is a scientific statement on renal denervation. I was pleased to be part of the working group. And what we suggest is first, measure the blood pressure accurately, verify outside of office. We know about the white coat effect and white coat hypertension, shared decision-making, and the patients can utilize renal denervation. I really don't think they're going to be able, they have true resistant hypertension to remove all medicines, but it may simplify the regimen. And some patients would rather just have optimization of medical therapy versus any intervention at all. All right, let's close for the next 3 to 4 minutes, and then we can have some discussion. Let's close on implementation. Again, this is another scientific statement from the American Heart Association and the AMA. No guideline. It's a scientific statement. It's a working group. Again, pleased to be part of this. And we looked at strategies that we can use in the United States to better control blood pressure. Going around the clock, this is the central illustration. Measure accurately. We do a very poor job, even in the clinical setting, of checking the blood pressure appropriately. The different colors include different professionals and non-professionals, physicians and other clinicians, nurse practitioners, advanced practice nurses, registered nurses, medical assistants, community health workers. It takes a team to control blood pressure. Lifestyle implementation. The artist here puts the picture of the various tools in the gymnasium. You really don't need to necessarily go to a gymnasium at all. In fact, I suggest walking, gardening, even housework. Just moderate activity, 150 minutes a week has a benefit. Standardized protocol. Don't leave it up to a guesswork. There are ways now that we can control blood pressure using combination therapy, the 3 major drug classes, the inclusion of mineral corticoid receptor antagonists. Improved adherence. Adherence is very poor with hypertension. After about 1 to 2 years, only 50% of persons are adhering to the regimen. And in clinical practice, don't ask the patient, are you taking the same medicines? The answer is going to always be yes. Go through each medicine, confirm for the patient that indeed they're taking it before prescribing a new medication. Quality improvement, financial levers, and anti-racist efforts. I usually don't even use the term racism. This is the term that was used in the implementation science scientific statement. We're here talking about structural inequities. If a person doesn't have insurance, or they're uninsured, or they don't have an identifiable source of primary care, we now have studies that those persons are going to have worse outcomes. So improving the access to quality care, improving insurance coverage will go a long way to improving the blood pressure control. This is my last slide, and this will lead us to have some time for discussion. The cartoon is from the CDC. It shows a little lady standing on the platform to reach the apple. She needs a leg up. She needs help. The words on the left are mine. We need targeted interventions to identify and eliminate disparities based on race, ethnicity, sex, gender, geography, socioeconomic status, ability, or disability. And you don't do it just because it's right. You should, but it's also a practical imperative. We waste money, we waste lives with stroke, the leading cause of disability, end-stage renal disease. Patients have to go to the dialysis centers, $90,000 to $110,000 per year. Heart attacks, heart failure, much of this can be ameliorated by the appropriate control of hypertension. All right, Dr. Williams, I left time. We can have some discussion of hopefully some provocative concepts and practical concepts regarding hypertension in 2025. Thank you very much.
That was really spectacular, Dr. Ferdinand. Really appreciate all of your insights and your lifelong interest in the area and the guidance that you have comparing guidelines and giving us these insights. I have a bunch of questions, but I want to. I'll start with one and see how far we get with folks adding in from the chat, as well as anyone who wants to come off mute. Feel free to go ahead and speak up. One of my favorite issues that you touched on briefly was the nocturnal hypertension issue, and we've had this data for a long time. It's a particularly African American problem and African urban, but not African rural problem, and it bleeds over into our choice of therapy. We see a lot of use of beta blockers still, which I see was way down on your list. And we, in our 2017 guidelines, we specifically said we really don't like using them as primary therapy, maybe fifth line or something down the road. And a lot of it was half-life, particularly metoprolol. I won't say any brand names, but if you look up the half-life, it's pretty short. You mentioned ARBs, and that is one of our major issues that so many people prescribe losartan with a 2 hour half-life and maybe a 6 hour, if you're lucky, metabolite, which is really not appropriate for the African American population or anyone with nocturnal hypertension. And the problem and the question is, what do we do about all of these payers and pre-authorization that try to deny all the other longer acting ARBs that would help our patients? I mean, why can't we get them to pay attention to the pharmacology when they're making decisions about the care of the patient without the patient?
Well, Dr. Williams, we only have about 12 minutes left. Medicine has become a dirty business, and oftentimes they'll mandate using a medication out of a class based on cost or access to the medicines that they may have in a particular pharmacy benefit. You're absolutely correct. There's a study called the LIFE study that looked at losartan in high-risk patients, and in the African American cohort, it showed really not much benefit. I still use it if I have to. 25 milligrams is basically placebo. You're going to need 50 or even 100 milligrams. It's a prodrug. Better if you can get access to the longer ARBs, telmisartan, irbesartan, olmesartan. But again, this is the business of medicine. If you use the three-drug combination of a long-acting calcium blocker, I've already showed a preference for amlodipine, the thiazide type diuretic, and a longer-acting ARB. I think you can get a lot of these patients that we are calling resistant hypertension. We can get them under control.
Those are excellent comments. I think we underutilize amlodipine because of the peripheral edema that happens at large doses. But our guidelines, and I don't think the Europeans disagreed with us much, keep multiple drugs in low doses, and then you don't end up with that edema thing. Uh,
Yeah, Yeah, let me make a point on that. It's
Please.
not fluid retention, it's arterial vasodilatation. So the blood goes down to the legs, and especially in middle-aged and older women, doesn't come back. If you add a RAS blocker to it, the RAS blockers are venodilators, so it can curtail much of that. Lower dose of the amlodipine with the RAS blocker, you don't see the same degree of edema you
That's
would
right.
see, for instance, with monotherapy of 10 milligrams amlodipine.
That's right. Dr. Krishnasamy, did you want to speak up or shall I read the question for you?
Sure, I can speak up. Thank you, Dr. Williams.
Great.
And thank you, Dr. Friedland. That was an excellent, excellent overview and really very helpful, very in-depth. And I appreciate you including primary hyperaldo, which has moved up in the algorithm, both at the European and the Australian societies. So that's awesome. And I just had a couple of comments, and I know there's a lot of other people waiting. One is regarding the primary hyperaldo. Is that no need to hold the MRAs if the renin is still suppressed on the MRA. So that is very helpful to know so that patients don't have to go through the procedure of holding it. And also, I wanted to know your comments about which you touched on regarding the office blood pressure and the home monitoring, because we see that all the time in downtown where they have to come, drive, park, get up into the office. And also in diabetes management, we do have samples and offer glucometers sometimes, but we don't have that with blood pressure cuffs. And I wish we could, have a program, or if you know of anything like
Yeah,
that. So
so you're going again back to the business of medicine. The reason you have the home glucose monitor is because Bill Clinton's mother died with diabetes, and they passed it that it be approved for persons who have insulin or difficult to treat diabetes. We don't have that same approval by Medicare and most of the private insurers. Some of the private insurers will cover home blood pressure, but it is a class 1 indication. And it is in the 2017 guideline that blood pressure be confirmed with out-of-office blood pressure. We do use home blood pressure measurements here in New Orleans. We did a pilot study, African-American patients, 2/3 with obesity, 2/3 with diabetes, mainly women. And we were able to show that if you had a Bluetooth device, and most of these new machines will Bluetooth the material back to the clinician. Some of it goes into electronic health record. It could be a standalone app. You can see the blood pressure at home, and then text messaging. We didn't call. In fact, I didn't do much. It was my wife, Daphne Ferdinand, who's a PhD in nursing, and medical students. Text messaging automatically increased adherence, and it led to significant lowering of blood pressure without any change in pharmacotherapy. So hopefully we can push to get that home blood pressure monitor now approved as a cost factor, similar to what we have for the glucose monitor. But unfortunately, if you really want me to tell you the honest truth, early in the morning, healthcare has become a business. They don't see the cost benefit of it. They're not going to approve it.
thank you so much. And I also wanted to let Dr. Williams and faculty and house staff know we have an excellent adrenal vein sampling program we set up in 21 along with the interventional radiology, Dr. Ba, and it's going really well. So please refer as many patients that you suspect to us, and we are happy to work with you all to get that going. Thank you.
That's a really good question. The temptation usually is to just add an MRA and see what happens. But that's because it's a great question for Dr. Ferdinand. Are you just satisfied, or you're concerned that that small percentage of malignant really needs to be checked out with a CT or vein sampling, or are you just happy with the MRA?
Boy, that's a big area of discussion. I don't know where it's going to end up in 2025. So on a population basis, go back to the Jackson Heart Study. Most of those patients weren't even using the 3-drug therapy. Less than 10% were using an MRA. So let's do that first. I think if you then test those patients for primary aldo and for renal vascular hypertension, you would only intervene for renal vascular hypertension if they had some of the following: flash pulmonary edema, rapid progression of CKD, inability to stay out of heart failure. Those are the patients maybe intervention would be, revascularization would be indicated. It's not indicated just for the conventional person, even if they have what appears to be significant renal artery stenosis. The CORAL study did not show a benefit in that patient, but without the randomized trials in selected patients, yes. In terms of primary aldo, a more comprehensive approach would probably be beneficial. I know the endocrinologist would help us in terms of guiding that, but still the aldosterone-renin ratio as a baseline will point you in the right way, whether or not you need to do more investigation of that.
Well said. One of the couple more questions for me, and then I see one from Dr. Kafkazi.
Kafkazi, yeah.
Let's just start with the issue that it didn't escape me that it said 2,400 milligrams of sodium, which is quite a bit higher than what we said in 2017
All
at
right. Okay,
1,800.
Dr. Williams.
And so
It
and
really
of
should be
course
much lower than that. That 2,400 is too high. I agree.
sounds good, particularly for the African American population. And
I agree.
I can't go an entire hour without mentioning plant-based nutrition, which is one of the major benefits, not just the microbiome, not just the inflammation effects on the vasculature, but a plant-based diet lowers your sodium dramatically, and it's just so easy to do. Dr. Gufgazi, did you want to say that's an interesting question you brought up there. Oh, I can actually read it, but you, sounds like he's having trouble. The
Thanks,
question
Dr.
is,
Williams. I'm sorry. I had a difficulty with unmuting. I was going to ask about the role of checking blood levels of medications. That's done in, specialist hypertension clinics, but usually not by cardiologists or internists who taking care of these patients. And given that adherence is such a huge problem, what's your opinion on that? And is that something that's practiced widely as far as you're aware?
It's not widely practiced. Mainly in Europe and Britain, they use blood pressure medication, urine sampling. It will tell you whether or not the person is taking any medicine. It really doesn't tell you the level of adherence, because if you take a little bit, it's still going to be positive. If you take it on alternate days, it's still going to be positive. Here's what I do. This is a clinical pearl. This is old-time medicine. This is the way they used to teach us when we were medical students. Ask the patient who's on multiple medicines, did you take your medicines last Tuesday? If the patient then starts to think about it, they're not taking it every day, because the person who's adhering will be able to say yes immediately. But if they start pondering whether they took it last Tuesday, it tells you a lot. And you can choose a date. Just pick a date: Tuesday, Wednesday, Thursday. In terms of sodium, the 2,400 is kind of one of those undervalued things. We now know in population samples out of Peru, we've also seen this in some Chinese populations, that if you lower the sodium remarkably down to 1,200 milligrams, the 2,400 is way too high. So I wanted to make that comment, Dr. Williams. That is what the scientific statement had stated in 2018. Maybe going forward, we'll push that 2,400 really down further.
I hope so. If I can switch
And
topics for another question.
If I
go ahead,
quickly
Chef.
just ask, how do you I keep scratching my head every time I want to talk about the sodium level. What do you exactly tell the patients? Like, who is able to measure their sodium intake? I mean, practically speaking, I have no idea how much sodium I take myself. So
I don't measure.
Okay.
Dr. Williams has a lot of
Absolutely.
clinical pearls on how to affect a low sodium diet. The DASH diet is inherently low sodium. There's a low sodium DASH that also does. It's an eating pattern. It's not a particular diet. We only have a couple of minutes left. You want to do something else, Dr. Williams, or you want to stay with the sodium?
I did. I'll just answer that one really quickly. And again, Shahab, you know what I'm going to say. It's a whole food plant-based diet. In 2017 guidelines, we said 3,500 milligrams of potassium per day and less than 1,800 milligrams of sodium. It's automatic. You don't have to calculate anything if you're doing beans, grains, nuts, seeds, fruits, vegetables, and mushrooms. Okay, but my last question for you, Dr. Ferdinand, is you brought up the Prevent calculator, and we were all very excited, and we bought the creatinine machines. We're doing our West End screenings. We've done over 1,100 people in the inner city, and it's going pretty well. And then the publication came out saying that there's a dramatic underestimation and people are reclassified as being at lower risk with Prevent Calculator. Makes me a bit nervous for our population with social determinants of health being in there. How are you feeling about it? Have you been using it a lot? When I compare them, I agree the Prevent Calculator comes out lower than the pool cohort.
Well, what we're doing now is we're looking again at the prevent calculator and comparing it to the pool cohort. Their 7.5 is going to be similar to 12 in the pool cohort. So you are going to get above 10% when you compare it to the pool cohort. And they also include now heart failure and progression to CKD. So it gives you a better estimate of overall risk. What I think may happen in the US going forward, both for lipids, hypertension, heart failure, is that if they use prevent calculator, what appears to be intermediate 7.5 will be deemed as high. So those are all nomenclatures. And
Yeah.
I think in general, if you include heart failure, CKD, the prevent will still say intensive treatment once you reach that 7.5.
Right. I think one of the major issues is, of course, for people who do not have a diagnosis of coronary disease, that pool cohort equation tells you whether or not to get the coronary calcium score.
I did an editorial for Jack, and I had a
Hmm.
weight on what we should use, and I put the coronary calcium score down there, regardless of race, age. Once you're over 40, unless you have familial hypercholesterolemia with LDLs of 190 or type 2 diabetes, that coronary calcium score is going to add a lot. And for the black cohort, it's better than HDL. HDL is not protective.
Right.
Stop telling our patients that they have high HDL, you're okay. That's just not the truth.
And U-shaped curve. I show it to them all the time. This has really been marvelous. I don't see any other questions in the chat, and I know we're a minute over. I just really want to thank you for all of those insights and an amazing discussion as well. And we'll look forward to hearing you on the Cardinal Minute and getting this information out there.